தெரியுங்களா? இப்போ வந்தோம்ல. அப்படியே நேரா ரைட் சைடு. பக்கத்துல அந்த ரைட் சைடு.
I'm in the iftar party, Sangram. Just finished and come.
Yeah. Good evening to one and all. I heartily welcome all the members of API, ICP Karnataka and other members of various organizations who have joined virtually from all over the country to attend this program on World Health Day. On this occasion, I welcome Dr. P.S. Shankar, Professor Emeritus, RGHS and KBN University, Gulbarga, Dr. Muruganathan, past Governor, ACP India Chapter and past Dean and President of API. I also welcome our own committee members, our patron, Dr. API, Dr. Maya Sir, Dr. Murali Mohan, Chairman, API Karnataka, Dr. Vishwanath, Secretary, Dr. Ravi Kirti, and Dr. L. Srinivas Murthy, Central API members. I welcome our today's chief guest, Professor Dr. Sanjay Tyagi, President-elect National CSI from Delhi, Chief Cardiologist and a great teacher par excellence, a renowned interventional cardiologist nationally and internationally, a great academician, received many awards and honors with many publications, taking National CSI to a great heights, both nationally and internationally. I also welcome our today's international speaker, Dr. Jagat Narula, presently the President-elect World Heart Federation, who will be joining shortly, a close associate of us, who was kind enough to accept our invitation and to address all of us from Houston, USA. Though he is busy in ACC conference Atlanta, he loves to address on this day that speaks his dedication and affection to all of us. He is a great teacher, researcher, scientist, and teacher of teachers with many awards, publications, a doyen in the field of cardiology, helping all our Indian colleagues who has passion for teaching. I also welcome our other speaker, Dr. Krishna Sheshadri, Chief Endocrinologist from Chennai, a master teacher, a great academician with many awards and publications. I welcome today's chief moderator, our own faculty, Professor Dr. Nagaraj Desai, Chief Cardiologist from Bangalore, a renowned teacher, a researcher who received many awards. I also welcome our today's panelist, Dr. Sadanand Shetty, cardiologist from Mumbai, a busy practitioner, a teacher and a great academician in Mumbai, heading many organizations like Lipid Association of India and others. I also welcome our other panelist, Dr. M.A. Shekhar, Chief Diabetologist and Vice Chancellor of Adi Chinchinaguri Institute of Medical Sciences from India, a dedicated person to profession, academics, research, taking university into the higher level and guiding all of us. Let us not waste time by reading their CV profile, which runs in pages. Let us learn and hear from them. As I can see, many have joined virtually from many states of the country, making a national event, which COVID-19 pandemic has taught a new normal life to learn. Lastly, I welcome one and all. And now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते शुभं कुरुत्वं कल्याणम्.
We are virtually honoring all our faculty as well. Now I request Dr. P.S. Shankar for your introductory remarks, sir. Over to you, Dr. P.S. Shankar.
Dr. Tyagi, Dr. Muruganathan, Dr. Narula, Dr. Seshadri, Dr. Nagaraj, Dr. Sadanand, Dr. Shekhar, Dr. Maya Murli Mohan, Vishwanath, Sangram, Ravikirti, LSM, colleagues and ladies and gentlemen. We have assembled today to celebrate the World Health Day, and as a part of it, we have organized a cardio-metabolic update in which distinguished faculty is taking part. I am glad to see Dr. Sadanand, my colleague in Mumbai, and distinguished student Dr. Nagaraj and Shekhar amidst us. WHO Day is celebrated annually, and each year it draws attention to a specific health topic of concern to people all over the world. The date 7th April marks the anniversary of the founding of the WHO in 1948. It will commemorate its 76th anniversary from its inception at the first Health Assembly in 1948, and since taking effect in 1950, the celebration has aimed to create awareness of a specific health theme to highlight a priority area of concern for World Health Organization. The organization has 194 member states. During United Nations conference held in San Francisco in 1945, a resolution was approved to establish a fresh and autonomous entity with the sole purpose of deliberating health-related matter. The first Health Assembly, named April 7 at the WHO Day in 1948. For the first time in 1950, the day was celebrated. Some of the notable themes of our environment, our health, creating a more just and healthy planet, and health for all, everyone, everywhere. The WHO Council on the Economics of Health for All has found that although at least 140 countries recognize health as a human right in their constitution, only 4 countries have mentioned how to finance it. To address these types of challenges, the theme of the World Health Day 2024, My Health, My Right, emphasizes a fundamental human right, access to quality healthcare. This year, the focus is on ensuring everyone, everywhere has the opportunity to live a healthy life. Around the world, the right to health of millions is increasingly coming under threat. Conflicts are devastating lives, causing death, pain, hunger, and psychological distress. The burning of the fossil fuels is simultaneously driving the climate crisis and taking away our right to breathe clean air, with indoor and outdoor air pollution claiming a life every 5 seconds. The year's theme has been chosen to champion the right of everyone, everywhere to have access to health services, education, and information, as well as safe drinking water, clean air, good nutrition, quality housing, decent working and environmental conditions, and freedom from discrimination. Health is a fundamental right of every human being. Health as a human right is recognized in WHO Constitution in 1948, the Universal Declaration of the Human Rights in 1948, and many international regional health rights treaties. All WHO member states have ratified at least one treaty that recognizes the right to the highest attainable standard of the physical and mental health. This means the countries have legal obligations while acknowledging that time and resources are required to fully achieve them. Some immediate obligations for countries include the guarantees of the non-discrimination and equal treatment in health. The right to health includes entitlements such as the right to control one's health, informed consent, body integrity, and the participation in health-related decision making. It also includes freedoms like freedom from torture, ill treatment, and harmful practices. The right to health is closely related to and dependent on the realization of other human rights, including the rights to life, food, housing, work, education, privacy, access to information, freedom from torture, and freedom of association, assembly, and movement. It includes both non-discriminatory access to quality, timely, and appropriate health services and systems, and to underlying the discrimination determination of health. every citizen has the right for safe and quality health care without any discrimination, privacy, and confidentiality in their health information. They about the treatment and the informed consent, bodily autonomy and integrity, and liberty to make decisions about one's health. Today, we are assembled to discuss on the cardiometabolic update, and this particular program was held nearly 40 years ago in Bangalore earlier, and today we are having here, and we are eager to hear the keynote address and the panel discussion on the cardiometabolic disorders. I am happy to be a part of this program and wish the program all success. Thank you.
Thank you, sir. Thank you for your kind words of wisdom. Now I request Dr. Muruganathan, sir, to say a few words.
Thank you, Dr. Sangram. At the outset, I must congratulate Dr. Sangram Bradar for organizing appropriate observations on various days. So today also, he has organized to commemorate, to celebrate the World Health Day. Health is not absence of illness. Health, according to WHO, it is overall wellness. It is emotional wellness, social wellness, physical wellness, all wellness comprehensive. That is why we want to have wellness all over. And the health is our right, as our Sankar sir was saying. So everyone should always have the health checkup properly. Like, everywhere, there are a lot of issues now, tensions, anxiety, especially during the election. There are so many now heat strokes, and people go in the summer to collect votes. They get into a lot of dehydration problem. So health is an overall healthness. I think we must create awareness about health. And today I have got a lot of my good brothers, Sadanand Sethi has come, Krishna Sheshadri, and our friend Dr. Tyagi, and all our good friends are there. So I wish you all a very happy, healthy, prosperous year. And I once again congratulate Dr. Sangram Bradar. Over to you, Sangram. Thank you.
Thank you, sir. Thank you for sparing your valuable time to join. Now I request our chief guest, Dr. Sanjay Tyagi, sir, for your inaugural. Before that, I request Dr. Murli Mohan for your welcome address from the API chairman, sir. Dr. Murli Mohan, sir.
Thank you, Professor Biradar. Again, to echo what Professor Muruganathan said earlier, I congratulate Dr. Biradar for observing all these and observing it appropriately with something as important as focusing on cardiometabolic health. This year's theme is My Health, My Right. And I just want to focus on these two words, my and right. So I think they're emphasizing that our health is our own and it's an individual responsibility. And like our rights are always accompanied by duties, I think it's very important that we have a duty to look after our health. And I think doctors in general are very careless about their own health while we focus on the health of others. So this is a call to everyone listening here and to spread the message that we are responsible for our patients, but equally we are responsible for our own health. It is our right and our duty to look after our health. So welcome to all the dignitaries, both national and international, who are going to participate in this extremely important event and talk about this extremely important part of our health, cardiometabolic health, as it impacts every aspect of our lives and is impacted largely by our lifestyle and by the environment around us. So it's important to look after these, look after the environment. As Dr. Muruganathan was saying, pollution is a major contributor. So it's our own responsibility to work as advocates, health professionals, and as individuals to improve the environment for not only our generation, but the generations to come. Hand over back to Professor Biradar, and thank you for inviting me to be a part of this session.
Thank you, sir. Thank you for your chairman's address. Now I request our today's chief guest, Dr. Sanjay Tyagi, for your inaugural address, sir. Mute. Kindly unmute. Dr. Sanjay Tyagi, kindly unmute and speak.
Good evening, friends. Thank you for your kind invitation, Dr. Sangram. We have eminent professors and cardiologists from Karnataka and all over the country and even abroad. Dr. Jagat Narula, I see, he has joined this. I think this the issue that you have chosen on this World Health Day is very appropriate. That is cardiometabolic disease. As we all know that cardiovascular disease are the leading cause of death in our country. As was noted in the publication in the Lancet, that coronary disease is characterized by, in India, is characterized by early age of onset, high relative risk burden, higher case fatality, and higher premature deaths. And in India, it is the major cause of death. And there are various risk factors. And as we know that many of these risk factors can be controlled. Cardiovascular disease, besides the this cardiodiabetes risk factor, include insulin resistance, diabetes, and also non-alcoholic fatty liver disease. Many of these risk factors have several etiologies and or pathophysiology in common. There are very common risk factors, particularly like abdominal obesity, high fatty triglycerides, low LDL, high LDL and low HDL levels, and elevated blood pressure. These factors are eminently controllable and treatable. So we can reduce the burden of this cardiometabolic disease in our country and reduce the morbidity and mortality and the economic effect of these risk factors. Also, recently, the inflammatory markers that C-reactive protein have also been shown to contribute to these cardiometabolic disease. Also, they are very common even in the cardiovascular disease, the metabolic disease, insulin resistance, also chronic kidney disease, which is also very closely linked in this disease. So, thank you, Dr. Shankar, Professor Shankar, and Dr. Biradar, for focusing on this very important issue of which we are facing in our country and is eminently controllable. So we must raise awareness among doctors, as spoken by Dr. Mohan, also in our patients, to control these risk factors and prevent the development of these diseases, which are eminently preventable by these simple acts of reducing your lipids, the lifestyle measures also. Thank you very much once again, and thank you for your kind invitation. I wish you all the success for this API conclave on this cardiometabolic disease.
Thank you, sir. Thank you for your kind words of wisdom and sparing your valuable time. Now we move on to the scientific session. I request Dr. Professor Nagaraj Desai, sir, to take over, as already the faculty have been introduced. Over to you, Dr. Nagaraj, sir.
Dr. Sangram, and also all the dignitaries, including my revered teacher, Professor Shankar. It is indeed very privileged to be part of this august faculty for discussing this topic, the so-called metabolic medicine, to occupy the central stage. Now, when we talk of cardiology, cardiovascular practice, and the metabolism and metabolic disorders, it looks like they cross each other at several points in life of a patient who is destined to suffer from cardiovascular diseases and metabolic related issues in his lifetime. It'll be interesting to know what the faculty have chosen to discuss on this particular day and how they want to kind of argue in favor of practicing cardiometabolic syndrome and bring it to the central stage so that our patients benefit and society at large benefits also. We know clearly that with simple actions by clinicians, several of the preventable cardiovascular diseases and metabolic disorders can be eminently preventable, as Dr. Tyagi was mentioning. Now, let's request Dr. Sheshadri from Chennai.
No, sir. Dr. Narula has already joined, sir. He's there.
Okay. Okay, we will request Dr. Jagat Narula. I have heard him several times, and in fact, I still remember about his talk on rheumatic myocarditis, a a kind of a very argumentative talk. It'll be wonderful to hear him speaking on this particular day. Professor Jagat Narula Saab, thank you so much for joining us.
Thank you so kindly, Dr. Desai, and grateful to Dr. Biradar and Dr. Patil Saab for the invitation, and outstanding comments by Dr. Mohan and Dr. Tyagi. I mean, I think they've set the stage here, and so truly honored to be with you on the World Health Day here. And my greetings to the Association of Physicians and Cardiologists of India, the Karnataka chapter. So I'll try to share my screen here. And so can you see the screen?
Yes,
Dr.
sir. Yes. Yes, sir.
Great. Thank you, sir. So, as we all know, that the World Health Day is celebrated annually on April 7th, which marks the anniversary of the founding of WHO in 1948. And this year, the theme is My Heart, My Right. And as we all know, that the World Health Day serves as an opportunity to draw global attention to a specific theme. And you can see the themes starting from 2001 to this year. And this is selected each year to highlight areas of concern and promote awareness and advocacy. And the activities on this day typically include public awareness campaigns, educational events, seminars, workshops, and health promotion initiatives organized by governments, health organizations, NGOs, and the communities around the world. The aim is to raise awareness, mobilize support, and encourage collaboration to tackle pressing health challenges and improve health outcomes globally. Um, the My Health, My Right has become the theme this year in the world where the right to health of millions is increasingly coming under threat. Disease and disasters, conflicts, the pollution, which are complicating the matter further. The WHO Council on the Economics of Health for All reports that more than 140 countries recognize health as a human right in their constitution. Yet, no laws are there to ensure their populations to the entitlement to the access to health services. So this year's theme was chosen to champion the right of everyone, everywhere, to have access to quality health services, education and information, as well as safe drinking water, clean air, good nutrition, quality housing, decent working and environmental conditions, and freedom from discrimination. So, this theme underscores the fundamental principle that health is not just a privilege, but it is a right inherent to every individual, irrespective of their background, socio-economic status, or geographic location. The health rights encompass a spectrum of entitlements, including access to healthcare services, quality of care, autonomy in health decision making, privacy, and dignity. These rights are enshrined in the international agreements such as the Universal Declaration of Human Rights and WHO Constitution. My Health, My Right encapsulates a powerful message, one that resonates with the inherent dignity and worth of every individual. As we commemorate World Health Day, let us reaffirm our commitment to realizing health rights for all. Let us stand in solidarity, advocate tirelessly, and work tirelessly to build a future where health is not a privilege, as I said, but a universal right, one that we safeguard for our generations to come. On part of World Heart Federation, which I would like to speak on behalf of, our mission is the cardiovascular health for all, everywhere. And as you know, that we have some strategic goals, and we want to have an impact in supporting the United Nations, the Strategic Development Goal 3.4 to reduce the cardiovascular disease premature mortality by 33% by the year 2030. The World Heart Day that we celebrate on the 29th of September, last year it reached more than 2.2 billion population. 2 billion potential reach was from the social media, 900,000 engagements, quite like likes, shares, comments, etc. And 135,000 results or posts with 6 hashtags in 2 languages that we saw. We are proposing the World Heart Vision of 2030, a vision for cardiovascular health that addresses the strategic challenges and opportunities the cardiovascular health community will face over the next decade. It is meant as an inclusive global vision for ambitious yet achievable steps, providing a platform for awareness, advocacy, and partnerships. So, for my health, my right, what can you do as an individual? So, obviously, we all know and so well spoken by Dr. Mohan, Dr. Tyagi, uh, and Dr. Desai that we need to educate ourselves. We are not the good patients. We have to be. We have to educate ourselves. We have to support lifestyle choices. We have to advocate for access. And what can we do as physicians is obviously the patient care, which provides equitable care. We need to start focusing more on preventive medicine and patient education. And as Dr. Desai said, that we have to have the personal action here. We have to be the model patients ourselves, and we have to believe in mentorship here. So I would like to bring in one important study of ours, which Dr. Biradar liked when we met in Mumbai, this year in January. And he wanted this to be the part of my little discussion with you today, was our study in Bolivia. And this is the Chimane population. It is a population of hunter-gatherers, which is a very long living population. People live into their 80s, 90s, and 100s, very healthy. And so we went ahead and started looking at this population. This is the population which is along the river Manuki. As you can see, this is a tributary to Amazon. And here I would demonstrate in this that we are flying over from the La Paz in Bolivia to Santa Maria, trying to get to the Chimane jungles. So this population is called Chimane. They have got their genealogic cousins who live in a city, and they are called Mozetans. So genealogically the same, but their lifestyle and their ages are very different. Their outcomes, disease outcomes, are very different. And when we reached there, from there to Chimane deep woods, we needed to go in the kayaks, as you can see there. And so initially, people used to just paddle there, but now they have the motors that they have fitted into their kayaks, and it takes approximately 3 hours to reach there. Previously, when they used to paddle, it used to take them 2.5 hours to reach the city. So here you can see that these are the settlements. People live in open huts, which is along the river Manuki, as I just mentioned. Those who live in the deeper villages, quite like as you will see on the right-hand panel, they even live better as compared to those who are closer to the river and who are nearer to the access to cities. So these are about 50 Chimane villages which are along this river. And so they are in a couple of important regions in Bolivia. And the more interior forests are in the Cuvierin region of Bolivia. Now, these people eat their whole day, they try and hunt and try and walk for hunting. As you can see here, that this is the person, and he has picked up one of the capybaras here, and it is on the back, which is walking back. They hunt from piranhas, as you can see here, and here it is not the nets. They use the arrows to get the fish, quite like as you can see here. And then they also hunt for monkeys, pigs, and jaguars, as you can see. And so they walk whole day, and they do about at least 15 to 17,000 steps a day. They also have some access to the wild fruits and grain, quite like here you would see that access to the plantains at less sweet as compared to the bananas. And obviously, I mean, I shouldn't be talking about it to the in the when I'm talking to the physicians from South India specifically. And then they also have an access to some of the wild papayas and some mangoes, which widely develop in those areas. And then they bring them back, they work on it, and they do the slow stew that they prepare on a slow fire, as you can see here. And they essentially literally eat once a day. So they are OMADs, the so-called one meal a day type of a culture. So they would prepare that. And here you can see that I'm seeing them because they have come for their cataract surgeries here. And this is one of my most favorite couple. And let me tell you that they are still alive. And so this is the 93 years old woman and her 85 years old husband. And so I saw them um, about 12, 13 years old. So this lady should be more than 100 years old now. And as you can see here, that they are all in the open huts. This is the entire family of theirs. And here is what they are cooking. So they have been said to be the healthiest hearts in the world. We have done 700 CT coronary calcium scores in them, and now about 3,500 carotid ultrasounds in this population. Looked at them in 2004, second cycle in 2007, and the third cycle in 2011. And as you can see here, that these people have the lowest coronary calcium score known to humanity. Essentially, if I compare them with the MESA study populations, you will see that everybody and every race in the world has higher coronary calcium scores, as you would see in the right hand upper panel. The upper panel is for the males and the lower panel is for the females. And as you can see here in the black line, which is the Chimane population's coronary calcium scores, which are just absolutely close to zero, as you would say. Less than 8% of the people reach the score of 100, even beyond the age of 80 years in this population. You will see in the women, it is even better. Compare them to anybody, whether they are Mahi, they are white, they are blacks, they are Hispanics, whatever you can think of, these people have done better. Or even compared to the Europeans, HNR study, or the studies that come from Korea, Japan. So this Chimane population has done exceptionally well. Now, the reason is what we believe, that their LDLs have always been less than 70. Their blood pressure has been less than, their systolic blood pressure always 115. Their fasting blood sugar does not exceed 80, and their BMI has always been under 25. And essentially, that does not give us any coronary calcium throughout their life. These are the people who don't smoke, they live in the open huts. There is no pollution, and they walk about 15 to 17,000 steps a day. So if they can do it, why can we not do it? And that Dr. Desai said that we really need to be a model for our patients here. So if we look at the various studies, and this is a beautiful description, which you have also used, I'm sure, in your presentations multiple times, and I have used it multiple times, that if you look at the primary prevention or secondary prevention, and if you place the LDL cholesterol on the x-axis and on the y-axis you put in the clinical major adverse cardiac events, you would see that when we do any of these statin studies, lower the LDL becomes, less becomes the MACE events. And to bring this line in the primary prevention, if you extrapolate this line to a zero MACE level, it comes out to be as 50, that your LDL will need to be down to 50. On the other hand, if we want to go for a secondary prevention, and here are all the studies of statin prevention with the in the secondary prevention population, you will see that you will need to have an LDL score of less than 30 milligram percent. And if you bring yourself to Dr. Braunwald's very elegant editorial, which just got published in the European Heart Journal last year, you would see that he had proposed, based on the model of Horton, that which was presented for the LDL receptor heterozygous or homozygous familial hypercholesterolemias, compared them to normal and compared them to those who have loss of function of the PCSK9. He had demonstrated, the Horton had demonstrated, that if you look at it, you need to reach a level which is the level that determines the ASCVD scores, or the ASCVD levels which are necessary for production of the event. So Dr. Braunwald, based on this, demonstrated or proposed that if we take the normals, normally it will be the 70 years when one would have an event if I do not do anything to protect myself. In that situation, he suggests that if you compare it with the familial hypercholesterolemia, you will see that you would be able to reach that level of atherosclerosis in your coronary arteries by the age of approximately 40 years. However, he suggests that if we start at the age of 35, and if we start to give a way to reduce your LDL down to about 50, for example, just give one shot of inclisiran a year, which is the mRNA therapeutics against the PCSK9, something which will work quite like PCSK9 loss of function. It will be able to protect you from developing that kind of atherosclerosis until the age of 100. And he proposed that one should be able to live to 100 without a heart attack. Now, when I was presenting the data at Mumbai, which is what we discussed with Dr. Biradar at that time, that if you look at all the animals all over the world, including the non-human primates, you would see that their cholesterol levels are less than 100. There is only one animal which is proud of its 200 cholesterol, and that is human. Not only that, if we look at our serum electrophoretic patterns, you will see that all the animals of the world, they have their HDL peaks superior to LDL peaks. Their HDL are higher. They are in the range of 45 to 60 as compared to LDL, which is about 25 to 35. So essentially, every single animal in the world has HDL, which is more than LDL. And the reason is that the animal keeps walking the whole day. On the other hand, there are two animals in the world where the LDL peak is greater than the HDL peak. It is human and pig. However, pig is much smarter than human, because in pig, the HDL levels are lower because it sits on its back the whole day, but their LDL levels still remain between 30s to 40s. It is only the human where the LDL increases beyond HDL, and which leads to the problems. Not only that, that you would see that we are born with 25 milligram of LDL, but within the 3 to 5 years time, our levels increased to 130 to 150, and that is the data that comes from the family study of Dr. Yusuf and Sonia Anand. And there is some very significant data that has come from the Army Hospital of India, which clearly demonstrates that the LDL levels start to increase within the first year. Now, what is it that leads to it? And that is the use of sugar in our sugar consumption in the formula which we feed our children, or the sugar that is given to them in one form or the other once the child starts to eat and is able to get to the regular food from the mother's milk. Now, the important thing is that in Chimane population also, when we looked at these patients from in 2004 and 2007, their LDL levels were between 30 to 70 and 70 to 90. But by 2011, their levels had increased from 70 to 110. And what we found was that that was the time when they found the motors to put in their kayaks, and they were able to go to the city and buy more and more of sugar sacks, which they consume with their stew. So the stew is becoming more like a syrup rather than anything else. So essentially suggesting that the sugar really leads to, and we demonstrated that in our very elegant proposal with Dr. Lucia and Joe Hill, that the sugar leads to the production of PCSK9, which removes the LDL receptors from the hepatocyte surface in children or in neonates, and it basically leads to development and increase in the PCSK9, and eventually causes the increase in cholesterol levels, and also does not let the HMG-CoA reductase pathways mature over a period of time. I would like to end with this particular study, which just got published in January, end of January, from Mount Sinai, from Dr. Miriam Mirad, where she has talked about the fasting in the human subjects. We knew it in mice, and so for the first time it has been demonstrated in the humans, where the transcriptomes have been analyzed with the food and fasting cycles. And what she's proposing here is the intermittent fasting. And here you would see that the monocytes upon fasting completely disappear from the peripheral circulation, suggesting that they will not cause the inflammation in the atherosclerotic plaques. However, the emergency recruitments of monocytes is completely maintained, or even better in event of the injury, trauma, or inflammation when there is an infective element there, clearly suggesting that the fasting is able to regulate our cells, our immune cells, much better as compared to anywhere else. So with my greetings for the World Health Day today, I'm grateful for the opportunity, and thank you, Dr. Biradar, for having me here. And if you do not mind, I will try to rush to present my next lecture at the ACC as I am here and giving the lecture from the conference center in Atlanta. Thank you very much.
Thank you,
Thank you, sir.
Professor
Thank you. Yeah.
Narula, for that nice presentation. As you're kind of in a busy schedule today, we can't hold you back, except to say a great, overview on how we are supposed to be dealing with our own health, and also communicate with our patients. And as the Interheart study clearly showed, that many of our risk factors or population attributable risk factors themselves are very much controllable, very much modifiable, suggesting that there's so much of work to be done amidst plenty, and amidst not need to move around too much. Even this Zoom platform are possibly making us more sedentary, I guess, not having to move from one hall to the other hall and listen to all the
Yeah. Thank you.
way of communication with our patients. So Dr. Sadanand, good friend of mine and a very active WhatsApper, as I call him, do you have any comments on his presentation, brief comments, so that we can let Dr. Narula go away from here? Thanks, Dr.
Dr. Sadanand is still in another meeting. So he'll be joining.
Then it's fine. Okay.
Yeah.
Anybody else from the panelists and from the faculty has any quick comment to mention here?
Krishna Shishadri, sir.
Okay, as none of the faculty at this moment
are Dr. Krishna, your comments, sir, anything you want to on this?
No, it's very interesting because of bringing in Dr. Braunwald's statement, because I'm going to start my talk with Dr. Braunwald's statement, and it's time to sort of put this all together. I think there is a big need to start thinking of these as one big basket and working towards. Hopefully I can highlight that when I speak also.
Thank you, Dr. Sheshadri.
Dr. Shekhar, anything you want to add?
You're on mute, Dr. Mysore.
Hey, Dr. Shekhar, kindly unmute, Dr. Shekhar. Kindly unmute it.
Asked to stay muted. Am I unmuted now?
Yes, fine.
Yes, you are.
Okay. So happy to be a part of this eclectical group of intellectuals. And Dr. Narula was exemplary in his activity. I just want to tell you about why we are getting into trouble. I was, once upon a time, we all were monkeys, it seems, in the evolutionary tree. And monkeys even today have a LDL of less than 30, a body mass index of 10, and their so-called lifestyle is to play around and eat nuts. Down the road, in a few millennia, human beings, their LDL has gone up to 180, BMI is 30, and their activity is to eat ice creams and grow abdomen. Maybe this is an evolutionary problem, not a problem with our food in a jocular way. Thank you, Dr. Narula.
Thank you,
really
Dr.
very
Thank you, Dr. Shekhar, and thanks. All these kind of thoughts come out of the Western Hemisphere, and it looks like about 100 years ago, Indians were famished and thinner, and we suffered in some other ways, possibly because of infections. Now we are possibly suffering because of plenty of food and plenty of conveniences. Let's leave it to that for the discussion time, and we'll let Dr. Narula sign off, and we will go ahead with presentations by Dr. Sheshadri, please. Dr. Narula, thanks once again.
Thank you, sir. Thank you.
Thank you so kindly. Thank you.
Thank you.
Dr. Sheshadri, please.
Can you hear me? Can I share my slides? 1 second.
Please go ahead.
Yeah.
Thank you. I just put up this sort of a provocative title. 1 second. Put up the slideshow. Yeah. Can you hear me?
Yes, sir. Yes.
Yeah, please.
Okay. Thank you. I requested Dr. Sangram if I can put up this sort of a provocative title. I think it is it's a testimony to how far we've come. Several years ago we discovered that there was an epidemic of diabetes. We needed to respond. Many of us learned diabetes as an additional specialty. Many of us practice diabetes, and we have and our patients are doing reasonably well. There is not our amputation rates have come down. Of course, our cardiologists have done well. The overall incidence of myocardial infarctions have come down, but the root of all of this remains the same. And it has taken a while for us to unravel that the roots of diabetes, cardiovascular disease, renal disease, MASLD are hidden in fat. And so it's time, I think, that we not talk about diabetes as a whole, but talk about from diabetes care to metabolic care. A few years ago, I had the privilege of spending an hour moderating a session that Dr. Eugene Braunwald spoke on, and he talked about, at that time, about cardiodiabetology. He said that the SGLT2 inhibitors are the statins of the 21st century, and at his age, it was my privilege to be in the same session with him. I also call upon a friend of ours, Robert Eckel, from the University of Colorado at Denver, who we have talked about, creating additional training programs that not just train people in diabetes, but in metabolic medicine. So I think it's time to upskill from diabetes to metabolic medicine, and the focus of our learning, the focus of our CMEs, the focus of our training in the next few years will require us to not just concentrate on glucose, but the specialty of metabolic medicine. I found an ally in someone who I respect a lot, and that's Dr. Mohan. And I've been talking to him for a while, and we actually came up with this particular editorial that's found in the Journal of Diabetology, that's brought out by the International Diabetes Federation, and you can access this. It was a big shot in the arm for me because I'm pushing this. And interesting to know that one of the All India Institute of Medical Sciences already has a DNB in metabolic medicine, or a DM in metabolic medicine. So it's important to start thinking about this, and let me explain why that most of us physicians should start upskilling into metabolic medicine. I'll present a patient. Here is someone who came to me, a 57-year-old, for treatment of hypothyroidism. And I've just cut and paste directly from our electronic medical record. We have a fairly good one, and all the information is captured. And you'll notice that when he came in, his TSH was 54, and at this point, and when I made this cut and paste of this particular one, his thyroids were quite fine. But you notice that over a period of time, that his initial weight was around 102, body mass index was 34. Now we do much more. We calculate hand grips, we look at fat, we do coronary artery calcium. But just let me give you the basic stuff. His creatinine was 0.9, but you look, he's already pre-diabetic. LDL was 171, right? So interestingly, he had a stop bank score, and I do this. These are simple stuff that we can do in our clinic. That, for example, this just looks at the age, the body mass index, it's more than 35. Whether this is a male, whether neck circumference is more than 40, are they taking blood pressure medications, or do they snore, would they wake up feeling tired? You can calculate a stop bank score. If it is more than 4, you could ask for a sleep study, and you'll notice that his apnea-hypopnea index was about 26.4. He was started on a BiPAP, but also counseled on weight loss and started on weight loss medications. But if you notice at the same time, if you we calculate a FIB-4 score, and our EMR automatically does it. But I do it on every patient now, and you'll notice that his initial FIB-4 score was 1.76. And with the FIB-4 score is more than 1.3, we actually get a fibroscan, and that's how we work. And you notice that he had significant steatosis. He had significant fibrosis. So in the past, we talk about this in diabetes, but I just want you to know a significant amount of patients in pre-diabetes have metabolic dysfunction. We just completed our own data. We looked at 110 pre-diabetic patients with an elevated FIB-4 score, and that is getting published. But I'm getting ahead of myself. Let me talk about it. Over a period of time, his sugars have gone up slowly, and somewhere around 13, 20, 23, the A1C became around 6.6. His body mass index was coming down. If you notice, his BMI was 33, then down to around 31. Remember, this is around 2023. These were his medications. He's on an SGLT2 inhibitor. He's on metformin. At this point of time, he didn't want a GLP-1RA, and for the NAFLD, he is on glitazone. But look at the problem: is pre-diabetes, hypothyroidism, vitamin D deficiency, type 2 diabetes, obstructive sleep apnea, obesity, hypertension, and NAFLD. So, we talk about diabetes a lot, but remember that this is a very interconnected system. This is a picture that looks at the system process in diabetes and how things are linked. The insulin sensitivity, the blood lipids, the glucose, the pressures, the oxidative stress, the inflammation, the gut microbiome. Each of these plays a part in amplifying or reducing the effect of the others. So when we look at things in isolation, it's like blind men examining an elephant. You really want to be upskilling yourself to look at all of them. And it all starts because we have interfered with the sleep energy cycle. One of the most conserved processes, and we were talking about longevity, the most conserved process is the sleep energy cycle. That when you're awake, you produce energy, and glucose is used because of photosynthesis, except in nocturnal feeding animals. When you go to sleep, there is rejuvenation. The brain shrinks to a third of its size. And I'll show you the mitochondria. The fuel partitioning works. The fuel is partitioned, therefore glucose is used during the day, fat is used in the night, and really glucose metabolism interferes with the fat metabolism; it suppresses it, or vice versa. The mitochondrial enzymes that are important, the rate-limiting enzymes, are also nocturnal, right? So when you eat at night, or when you're eating when you shouldn't be eating, that does interfere. I don't want to get into the intermittent fasting discussion. We can during this thing, but the important thing to understand is when you play with nature pushes back. And one of the things that has happened is the mitochondrial rate-limiting enzymes are changed. They are called into play. There is a process called hysteresis that occurs. Therefore, there is oxidative stress, and this occurs in every cell in the body. At some point of time, we have caloric excess. The fat expands. When the fat expands, other things happen. I've talked about this many times. I won't spend too much time on it. But the important thing is that as we gain weight, and more important than the weight, when fat starts accumulating, changes occur. The most important of them, of course, is that the monocytes that are present, again, people talk about monocytes in intermittent fasting. The monocytes that are present there's a particular thing called MCP1, monocyte chemoattractant protein 1, that is present when the fat cells have insulin resistance, affects the mTOR pathway. But when that happens, the MCP1 sends a signal to the bone marrow, asking the T cells to come into the abdomen. These are actually helper cells, but they undergo a phenotypic shift, and there's an increase in lipokines and adipokines. But to cut a long story short, that as you become overweight, there's a change in the vascular endothelium, there's MASLD, simply because it's fat apoptosis. The fat becomes systemic, and the first stop is the liver. And unless you get into the liver, there's no insulin resistance. As your weight goes up, there's an increase in risk of CKD, heart disease, and of course cancer. In addition to all of this, the kind of food we eat, the times that we eat, also, and we were one of the first groups in India to show the relationship between diabetes and gut microbiome. There is a change in the gut microbiome that promotes inflammation. Remember that our microbiome are inherited maternally. And if you were to believe C. elegans, you will find out that many of the epigenetic imprinting that occurs lasts for 14 generations. You change what your mother ate, her mother ate, her mother ate, you're actually changing commensal organisms in the body that are there to protect you, and you lose that protection, right? So to come back and put it together, diabetes is only one manifestation of a cluster of abnormalities that occur when the environmental influences interact with genetic predisposition. These are food related, activity related, sleep and light related, right? And there is a big and these are together. Diabetes is just one thing. And remember that it's a continuum, that it is not a all or none phenomenon, that there's a continuum as there is caloric excess, as there is weight, as is an interaction with, for example, processed food that your culture is not used to, right? All of these create issues. The consequence of these interactions include food excess storage of fat, the loss of partitioning of fuel, a change in the mitochondrial bioenergetics, leading to a change in fuel efficiency in critical organs. Remember, as Arthur Guyton says, that the purpose of life is ATP to ADP and back, and that's done in the mitochondria. You change it, everything changes. This leads to inflammation. And remember, the body knows how to react to threats by only one way: acute or chronic inflammation. It's fat apoptosis, ectopic fat, and that leads to organ dysfunction. So adiposopathy or obesity, a result of caloric excess, predisposes to obstructive sleep apnea, MASLD, osteoarthritis, hyperlipidemia, hypertension, coronary artery disease, and diabetes. And these feed on each other. While we become glucocentric, we forget this big basket, and that's the reason why we need to start thinking about metabolic medicine. So clearly, this is a metabolic conundrum that starts with the fat dysfunction that could have a genetic predisposition, but ultimately works through the liver and causes issues. I talked about this, that when fat dysfunction occurs, there is T cell interaction, and then there's fat cell apoptosis leading to accumulation of fat. The proportion of diacylglycerol in the liver is directly proportional to the insulin resistance. And without diacylglycerol in the liver, there is no insulin resistance. So clearly, this is a key step in the pathogenesis of both cardiovascular disease, with CKD, with stroke, and with diabetes. So the phenotypic expression of these abnormalities may be linear, or they may occur simultaneously depending on the genetic risk or the kind of environmental influence or the epigenetic imprinting that has occurred. But these run together: obesity, metabolic syndrome, diabetes, cardiac and renal dysfunction, NAFLD, obstructive sleep apnea, cognitive dysfunction. And interestingly, 2 days ago, there was a very interesting article that was published that showed lixisenatide improves Parkinson's disease. There's other data about it in liraglutide in dementia. So clearly linked, and of course dyslipidemia. MASLD, or metabolic syndrome associated steatotic liver disease, is an anchor. There is an increase in triglycerides, small dense LDL, HDL is lowered, change in the renin-angiotensin aldosterone. Axis on the one hand leads to nephropathy, retinopathy, and atherosclerosis. The other hand, it causes progression of NASH and cirrhosis, but also these feed into diabetes. Here is this particular patient. Can you see the FIB-4 score? And if you notice that this person has steatosis and fibrosis. This is our own study. It was just accepted the IDF as an abstract. We're writing it up, but it's now come out as an abstract in the DRCP. Very interesting. This is our diabetic patients, and 880 of them we pulled out, of which 748 had a FIB-4 score, and of which a third of them had an elevated FIB-4 score. A third of them had an elevated FIB-4 score greater than 1.4, 30%. And interesting, a mean score of around 2.4, it was 1.4 and was elevated. And interestingly, of these, a third had an F2 or greater fibrosis. I'm sorry, that slide is not here, but if you look at it here, you'll see that a third of these people had a fibrosis of more than F2, and that is very interesting, right? And we just pulled out our pre-diabetes data. We looked at about 120 patients where the FIB-4 score was available, because we started calculating FIB-4 scores in pre-diabetes very early. So this is something very interesting, that even when you don't have diabetes, you just have pre-diabetes, the FIB-4 scores can go up. and hopefully we can present that data. And this is the can predict NASH and fibrosis. So clearly, the presence or exacerbation of one component affects the expression and outcome of another outcome. So if you have cardiac or renal dysfunction, it affects cardiac and renal outcomes. And I'll show you MASLD does the same. And importantly, obesity. We've never talked about obesity and progression of disease. But and this data was not available for a long time. But look at this. If you're obese, irrespective of the other factors, there's an increase in progression of CKD. There's an increase in progression of retinopathy, increase in progression of neuropathy. Interestingly, while we talk about it, what if we just lose weight? What if we don't take a drug? Do we achieve A1C? Very interesting. And remember, it's a continuum. If your A1C, your weight goes up by around 3%, you can see that your A1C goes up, right? If your A1C is sort of there, it's the same. If you decrease 3 to 5%, your A1C comes down by 0.3%. But see what happens when you lose weight by 10 to 15%. Your A1C comes down, and this is without any other drug, 0.8 to 1.2%. Many people go into remission. So clearly, whether it's weight loss or reduction in fat, and I tell you it's reduction in fat, and I'll give you some examples, that A1C reduces. Here is a 10-year data from Sweden that tells you what happens when you weight loss. This is less than 5 kg, and look at it, your weight loss medications come down to around 56%. Less than 56%. I mean, 56% do not have to take medication. When you lose 10 kgs, 75% are not on medications. Greater than 10 kg weight loss, a significant number. Remember, very, very small study, but other studies are showing the same thing. You lose weight irrespective of your BMI, you come off medications. Let me use NAFLD as an example. This is 52 weeks of lifestyle intervention. If you have 5% weight loss, there is NASH resolution and there is fibrosis regression around 45%. There is 7% weight loss. If you have 10% weight loss, there is 65. There's about 80% reduction in fibrosis. There's 100% improvement in steatosis. Only about 10% achieve 10% weight loss. But if you're able to motivate patients to lose weight, there is clear regression of fibrosis. That's much more impressive than most of the medications that we use. What's happening? You have weight loss. Here is a type 2 diabetic, the liver fat of about 36%. You lose weight by about 15%. Your liver fat is less than 2%. Clearly, the insulin resistance in the liver is gone. The effects of it outside is gone. There is benefit. That's why people now talk about the personal fat threshold, that it doesn't matter what your BMI is. For each person, there's a fat threshold at which the complications increase. And this is true that one disease worsens outcomes. Here is looking at EGFR and what happens to CV outcomes. This is an EGFR less than 30 to 60. Can you see? And this is less than 30. You see the MACE is going up. This is EGFR plus the status category, whether it is stage. This is plus microalbuminuria. The MACE is going up, and more importantly, the heart failure. Can you see how this plays in? This is looking at DKD on various outcomes. This is myocardial infarction, and you can see the stage of the DKD is here. The higher the stage of DKD, the greater the hazard ratio of myocardial infarction. The higher the DKD status on CHF, the higher on stroke. So clearly, the primary disease, irrespective of in a diabetic patient, irrespective of age, hypertension, sex, stage of the DKD affects the outcomes. What about CHF, NAFLD? You look at this. If there's diabetes, see what is happening to NAFLD to NASH, NASH to cirrhosis, cirrhosis to mortality and liver transplant. So clearly, one second, I just wanted to get one more. So clearly, what we realize is that one disease affects the other, and if you just look at one in isolation as diabetes alone, we miss the bus. We need to look at all of these. So where does the primary care physician come in? A holistic approach to care improves more than the expression and outcome of more than one component. In addition, medical therapy of one component improves the expression and the outcome of the other components. For example, there's a direct study. We've talked about it ad nauseum. Remember, the direct study was done in primary care. People were randomized to total direct replacement or diet replacement for 8 weeks, addition of vegetables, then natural foods were reintroduced. Now, if you had lost 15 kgs, at the end of year 2, remission was around 64%. At 10 kg, 64%, 86% at year 2 if you had 15 kgs. Now, does treatment of diabetes improve diabetes outcomes? And the answer is if you lose weight, and this is looking at surgical versus non-surgical scores. But what you realize is that if you lose weight, your outcomes improve. And whether you do it by metabolic surgery, by lifestyle, or even a hybrid fashion, there's an improvement in outcomes. In fact, this is something that we knew for many years. This is 1994, if I remember right. 95. This is Poris et al. Who thought that an operation proves to be the most effective therapy for adult onset diabetes. But today we also have drugs that bring in the weight loss to almost what metabolic surgery does. The GLP-1 there's tirzepatide, the glucagon co-agonist, all of these do that. Here is a very new study that talks about how, I use an example of DKD, but see what's happening. RAS inhibitors, you have SGLT2 inhibitors, you have non-steroidal MRAs, you have GLP-1 they reduce the risk of DKD progression, right? Death from renal cause, but there is a bidirectional improvement in CV risk, CV cause, hospitalization for heart failure and stroke. This is our own study that looks at FIB4 and using of 2 drugs, pioglitazone and SGLT2 inhibitors. And look at the FIB4 score after pioglitazone, reduced numerically, small, and we use 7.5 milligrams. And this is the SGLT2 inhibitor, and a combination of these being statistically significant. Again, accepted, and it's an accepted abstract in 2025 of the ADA. We'll have a publication out hopefully. So what we know is that the care of the initial expression of many of these conditions are better done by primary care physicians, with additional training allowing care of more severe expression by subspecialists. So my case is to upskill us into metabolic medicine as primary care physicians. We need endocrinologists, we need other diabetologists, we need cardiologists, we need nephrologists, but the initial care must be done in a more expansive manner, and we have the tools. We have electronic medical records that calculate many of these. We have non-invasive tools like the QRIS-3. We have ACVD risk calculators. I use coronary artery calcium scores a lot. I use NT-proBNP as a screening tool in my primary care, which I never did many years, but many of my patients now get annual NT-proBNPs. This is very, something I thought I'll add. This is a very interesting story. This is the LDL score, and you multiply it by age. If it's more than 5,000, your risk increases, right? So this is where it is. And for example, if your LDL is 200 at the age of 20, and it becomes 5,000, and this is at 40, you really, your plaque burden increases. It acts like a CAC score. This is CKD. We have the KidGeo scores. Care is now easier. You have AI-based tools. You have digital tools that will help us. I think it's time to move up. So what should we do? We should upskill. We should rediscover. We should upskill in 3 places. One is metabolic medicine. We should upskill nutrition. We should upskill data science. And we should rediscover ourselves and improve ourselves. It's time to move away from just diabetes care to metabolic care. Again, my thanks to Dr. Braunwald, Dr. Bapat Ekal, and of course, Dr. Mohan for helping me go on this. I'm going to stop here, and I'll be very happy to be part of the discussion. I hope this was sort of a, more than an evidence or any other based talk. I wanted to give a sort of a provocative talk, urging people to start thinking a broader picture than this. I hope I was also on time. I'm going to stop sharing. Thank you so much, Dr. Biradar, for consistently placing faith with me year on year. Thank you.
Thank you, sir. Thanks.
Thank you, Dr. Krishna Sheshadri, for that wonderful overview, arguing in favor of need for upskilling the physicians, and importantly,
Yes, sir.
you brought out the recent publications, not only in diabetology but also in cardiology, trying to emphasize the way in which the pendulum is moving. And we are looking forward to hearing from other experts. If Dr. Shekhar is joining us in this.
Dr. Sadanand Shetty has also joined, sir.
Yeah, I will come back to him. I'll come back to him. After Dr. Shekhar, let's move to Dr. Sadanand. Either of them is fine as far as the discussion is concerned. I would love to hear from both of them right away. Thank you. Dr. Sadanand, Dr. Shekhar.
Just, another session got over and I was talking to Sangram. Oh, you can hear me, no?
Yes, yes. Yeah,
You can hear me, yeah. We had another session going on, international speaker program. I just got free, so I was a little late in joining this program. So basically, as I was just listening to Krishna Seshadri, how our metabolic medicine currently, particularly the only one new drug, I don't know whether Seshadri, the one resmetirom, which is thyroid agonist, like a liver targeted, recently approved by FDA. So that whether you got anything, some detailed information about that. And the other thing, what you mentioned about the pioglitazone, even the smaller dose. Initially, FDA was mentioning pioglitazone 15 milligram 3 times, which is quite a heavy dose. Now with advent of 7.5, even 15 milligram is doing as good a job as a 45. This should be a good point for us actually at the moment, till we get that liver targeted thyroid agonist receptor drug. Anything on that, Seshadri? Yeah.
Yeah, so it's interesting that the T3 receptor agonists have been under development for many years.
Yeah.
But the issue has always been that T3 is such a universal drug. It doesn't that it can cause palpitations. It can cause increased cardiac metabolism, and it's always a double-edged sword.
Okay.
So this is a very interesting addition to the armamentarium. Hopefully, we'll have some more studies that look at this, both not just as an MASLD, but improving, but also in looking at adipocyte function, because ultimately, this is all it goes. Some of the research on beiging of fat was also centered on T3 agonists. So it'll be interesting to see what happens to uncoupling protein 1 expression, what happens to fat metabolism at a cellular level. So this is an exciting space, and I think the push for greater use of metabolic syndrome, metabolic medicine as a broader specialty is apt at this point of time. The pioglitazone bit, I think our data was interesting because about patients who had basically it is a real world data, so we need a prospective study. But these were patients who were on much smaller doses, and the FIB-4 score actually did come down. So, and remember, it's very interesting because the liver, the major receptor is PPAR alpha. That's why the glitazars are so good. But even the glitazones, they do work on PPAR alpha, and that's really why TZDs are such a good drug, and even in the same.
Any additional comment on the topic that is being discussed, Dr. Sadanand?
I just joined, so he just asked me some, because I really don't know.
Oh, okay, fair enough. No issue. Yeah. Okay, Dr. Shekhar, do you have any point to kind of elaborate upon whatever was not covered? Dr. Shekhar? In the meantime, Dr. Sheshadri, there is one comment, a couple of comments by a couple of people here. the sleep disorders and the sleep health. What is your advice to your patients in your practice?
That's a whole lecture on its own. But
Sure, I agree with
the
you.
important thing is that circadian rhythms are hardwired. I think that is something that we need to sort of remember. That it's very interesting because when I first started working on this, and we have some studies on sleep and this thing, I never realized that it's not just the light; it's also the heat. And interestingly, our ancestors seem to have recognized what is it called? The Aditya Suktam talks about the heat of the sun setting the clock. I never realized that. That our clocks are set to. I always thought they were set to light. It's also the heat, right? So also, the environmental temperature needs to vary. It is not just the light. If you still follow the light, but you're not exposed to varying environmental temperatures, I'm sure there is mitochondrial dysfunction. But the important thing is that light is so hardwired to us that it's the principle of fuel partition, right? And you interfere with it, you interfere with nature, right? For example, and I'm just giving you another example how our ancients were in tune with this. If you go to a temple today, there may be multiple Naivedyas, but there are only two mantras, one for the morning and one for the evening. Satyam Tatvena Parishinchami and evening Dhrutam Tatvena Parishinchami. The last Naivedya used to be at sunset, right? And then people would sleep, right? The last meal was consumed at that time. So there was a harmony with nature, but maybe they didn't know. They knew fuel partitioning, they did not. But the important thing is fuel that fuels where the nature works by fuel partitioning. When fuels mix, there is mitochondrial dysfunction. The efficiency at which the respiratory chain functions goes away, right? And that's how sleep disorders occur. You need X amount of sleep. It is not just sleep, it is darkness.
Yeah.
We say sleep, but the correct answer is darkness, because it is also important. For example, it has been shown that television screens, cell phone screens, charging lights all disrupt the environment.
And mobile phone.
Yes. Okay. Yeah.
It is sleep and darkness that works. And we actually showed very interestingly that the HbA1c, and I'm talking 10 years ago, HbA1c was correlated with the PSQ1, the Philadelphia Sleep Question. The greater your HbA1c, the greater the sleep disorder. It's probably bidirectional. The sleep disorder worsening the A1c, but probably also worsening diabetes, worsening sleep. So yeah, get to sleep early today also.
Okay. Now, in fact, sleep has been considered as one of the important factors for better health, even in cardiology or cardiac medicine. We call it as the eighth factor, which American Heart Association recognizes now. That is the reason why, as a cardiologist, I was interested in. Thanks for that explanation by you in a very traditional way. Let's go back to Dr. Shekhar. I think Dr. Shekhar is ready to kind of.
Yeah, okay, I fully agree with Krishna. When it comes to the thing, he is an extraordinary scholar when it comes to Sanskrit and medicine. Maybe I'm good in medicine, but I have very little idea about what is how to speak Sanskrit. But I remember there is a shloka, as he said, which says, "Follow the sun." For millennia, Earth has been rotating, and light cycle and dark cycle has been going on for thousands and thousands of years. Evolution has revolved around this revolution. And in Sanskrit, it says, follow the sun. When it's up, you do your activity. When it's down, you be silent. Very simple concept. But I would like to put two bits here, which may be a little bit modeling or philosophical, but I still feel I should be able to talk to you because I have a white hair. Okay. The two concepts is the insatiable searching nature of human beings. We are not going to stop. And the very reason, philosophically, my Swamiji, my chancellor from the Adichinchikul University, said, it is the fear of death, the mortal fear of death of human beings makes us do two extraordinary things in our life. One is sacrifice. The other one is never to give up. And we have never given up, and it's going and going and going on about how we can preserve health, how we can be very healthy. I would like to bring to you a concept called as salutogenesis. For 600 years, modern medicine looked at pathogenesis. Why human beings become diseased? What are the causes of disease? But Ayurveda had in English called salutogenesis. In spite of a disease-causing environment, why are we healthy? What a great, fantastic idea. For this, two things happen. The conundrum or the duality of lifespan and health span. We live for 70 years, but are we healthy till we die? That's the big question that has happened. At the midnight stroke of August 15, 1947, lifespan and health span was the same in India. After 75 years, it is totally divergent. Why? This is the reason. The healthy metabolic activity, for whatever reasons, we have led on to unhealthy activity. And Krishna has given a fantastic idea why it is changing. But I would like to bring finally a 2-bit concept of blue zones. I'm sure you all know about blue zones. In spite of all this disease-causing environment, in spite of we being healthy, there are 5 zones in the world where people live very happily, very low incidence of dementia, even at the 90+ years. I'm sure you know Dan Buettner. He was not a doctor. He is not a doctor. He is a journalist. He went all around the world and found out there are only 3 or 4 things. The way we live, the way we eat, the way we interact with people takes care of our metabolism. We, instead of looking inward into these concepts of healthy lifestyle, etc., we are in an insatiable drive to look at drugs. Every other day there are new drugs that are coming in, and I'm sure it is not the answer. The way we live, the way we eat, the way we interact with our people probably will bring back the metabolic health, which I strongly believe. Thank you for this opportunity.
Oh, thanks, Dr. Shekhar. As usual, very elegant in his approach to the to the medicine and to life. And let me just kind of revert to Dr. Sheshadri. There is a question on pioglitazone. In fact, just about couple of decades ago, we as cardiologists were a little weary about it. Maybe we did not learn about this particular medicine too well, nor possibly we used a little more. And with all respects to Dr. Shekhar, when he's talking of non-medical medicine-oriented intervention, we should be concentrating on life as in general. Let's try and understand from Dr. Sheshadri what he thinks about pioglitazone in current perspective with the new data emerging out of cardiovascular protection. What's your take on that, sir?
So 2 or 3 things. One is that it's always been a mixed bag, right? So the quality of studies that pioglitazone has undergone have always been questioned. But if you look at it carefully, the IRIS gives you some sort of an example, but even the IRIS has been questioned. What we know is that because pioglitazone is such a lipoactive drug, right? It reduces the lipotoxicity on cells. This is the first part, and that's where its great benefit is. Having said that, right, there is also if you have class 2 or more CHF, you really don't want to be using this drug. But other than that, I think pioglitazone becomes emotional based medicine more than evidence based in many places. But I think we've been a little unfair to the drug. That it does have cardiovascular safety, it does have benefit, but the important part is that the caveats of heart failure are still there. Maybe the non-cardiologists should be using a lot more of this, especially now with the NAFLD data. I think the NAFLD data is very, very interesting. But the glitter zones are pretty much taking a lot of center stage on it. We will see these new drugs coming in. I know the West is pushing so heavily on and rightfully on tirzepatide and the others. But the glitter zones are indeed, someone has said, a poor man's GLP-1 RA. I think someone had
Yeah, I
mentioned
saw that. Yes.
But I think it's a very interesting part.
How about the weight gain associated with pioglitazone? I am just concerned about that. What's your take on that?
So I always combine it with an SGLT2 inhibitor.
Sorry?
Combine it with an SGLT2 inhibitor. They work well together, right?
Oh, okay. Fair enough.
The
Thank
second part is, this is very interesting, and that is this. You have a lot of worries about, especially, remember also in the elderly, it does cause fractures. But your worry about weight loss is loss of muscle. And there's an old trick that I learned from Dr. Franzo is that you add a small dose of glitazones, the amount of muscle loss is reduced. Right? So it doesn't cause muscle loss. It actually, so two drugs don't cause muscle loss. One is a DPP4 inhibitor, the other is a glitazone. All the others are associated, including SGLT2. SGLT2 inhibitors is a greater fat loss than muscle loss, but there is some amount of muscle loss, right? And apparently the glitazones do protect you against muscle loss. But the simplest way to offset the glitazone-induced weight loss, one, use a lower dose in India. That's just something that many of us do. The second thing, of course, is add an SGLT2 inhibitors. They are made for each other.
Excellent. Very good, sir. Thank you so much. In fact, we are almost coming to the fag end of the program. In fact, if there any kind of final comment from either of the panels, may I like to request them. Dr. Shekhar and Dr. Sadanand Shetty, please. If there are none, may I sorry, Dr. Shekhar, go ahead.
Yeah, okay, Shekhar, you can carry on. Yeah.
It was an extraordinary meeting, and I'm sure we will be talking about metabolism for the next 10 years till we leave.
Thank you. Thank you so much. Well, that's a wonderful comment. In fact, this concept of care of the patient as a whole has been on for several decades and centuries. And as during Osler time also, he did mention about the compartmentalization of medicine is an unfortunate part of it. It should be that the holistic approach to the assessment of the patient is important, and the evolution of the health of a person is not static. It is going to progress. So one should be alert to that possibility. And indeed, there is so much of care that should be given to the patient beyond the medical prescription. That's what was brought out elegantly by the two speakers of great standards. We greatly appreciate, and on behalf of all of you, I thank both of them, and I pass on the mic to the organizers for this meeting. Thank you so much for this opportunity, Dr. Biradar, please.
Thank you, sir. We will have a comment from Dr. Sanjay Tyagi also. He's also still there. So your comments on the...
Okay. Sure. I have
I think the talks were excellent, but the facts that have been brought out are being now discussed in cardiac journals also, particularly the cardio, metabolic, and gut being responsible for cardiovascular disease that Dr. Seshadri also pointed out. And I have seen patients who have lost weight, obese patients lost weight, and their diabetes medicine requirement disappeared. Like a patient underwent bariatric surgery and lost 40 kilogram of weight, and all the medicines, the diabetic medicines that he was taking was not required. So the fact that obesity leads to diabetes is very valid, and also obesity leads to inflammation. Inflammation leads to the rupture of atherosclerotic plaques. So as Dr. Nagaraj Desai has pointed out, that we need to see patient as a holistic approach and not compartmentalization like into cardiology or endocrinology. The patient needs a comprehensive approach. So wonderful discussion brought out for the benefit of all of us and for the benefit of our patients. Thank you very much.
Thank you. Dr. Sadanand Shetty, your take-home message.
we have this epigenetics. We consider cardiometabolism to some extent is more like an epigenetic. How to take care of these environmental, what I'm saying, like a sound pollution or noise pollution, air pollution, what role we have there? Because that's a significant, the measure accounting for this, togetherness, genetic predisposition, and on the top of that, the environmental factor, which are not in our control. I personally feel this is a major area, though we talk about our own health, like regular exercise, diet, all those things, fine. But what about the environmental health factor? What we have, what we should do about it? What do you say, Seshadri? You got any comment in that? Because that's a major factor according to me.
Right, but let me. I mean, I'm sure we can have a big discussion on environmental health. But I think as humans, our own interaction with the public environment is also important.
Yeah.
Right. For example, I have big discussions about just taking the metro to work, or going to the airport in a metro rather than driving our own car there. Right. How difficult is it to forego? We have this discussion, and I always say that a country is rich not by the number of people who own big cars, but by the number of rich people who take public transport. Right? We can start there. We can start by allowing public spaces to be not occupied by hoardings and others, where people can walk. Today, I don't recommend walking in the streets for our patients, simply because it's not the lack of a footpath, but the obstructions in the footpath. Everybody thinks it is their right to drive on the footpath, to park. There are lots of things that today discipline is a bad word. We have become so woke that we think that that personal discipline, including in public spaces, is a bad word. For example, you travel in an aircraft or a train, we don't respect other people's right to being quiet. We think singing loudly and working with our cell phones is a big thing. Our roads are not safe, not because the roads are bad, but because we don't drive safely. While there is a big part of the government being part of it, but I think it's important for all of us to start learning to respect public spaces as an important part of overall health. Right? I'm taking the onus away from the government. It is still there. Our onus is to also elect governments that are responsible and responsive to us. I think we should talk about discipline. Self-discipline is the first step towards public discipline.
Thank you so much, Dr. Sheshadri and Dr. Sadanand. I hand over the mic once again to Dr. Biradar to make his comments before we conclude or leave the podium.
Yeah.
So much.
So before Dr. Vishwanath propose the vote of thanks.
Yeah. Good evening, sir. Thank you all for this wonderful session, and highly appreciative of the talks and our chief guest, Dr. Sanjay, and all the other chief guests. Dr. Narula, I think, is one of the best talks with all his experience, research studies. I thank Dr. Nagaraj Desai, sir, for moderating this wonderful and session. And as usual, when Dr. Krishna Sheshadri, sir, and Dr. Shekhar is there, always, I feel that elegance and eloquence just flow. They're a wonderful combination of two, and somehow they are able to, give all the required information in that short span. Thank you for that metabolic medicine concept. Yes, I think we do have to, from API, take it up more seriously and, make it a bigger program. And I thank our chairman, API KC chairman, Dr. Murli Mohan. And special thanks to Dr. Biradar, sir. As usual, he is our engine of all the CME programs, bringing in the best faculty across the country and giving us this information. Thank you all. Thank you once again. Thank you all the participants. Thank you.
Thank you.
Thank you, sir. Thank you, one and all.
Good night. Thank you for this opportunity. Thank you.
Thank
Good
you,
night.
sir. Thank you.
Thank you, Dr. Krishna.
Thank you very much.
Thank
Good
you, sir.
night.
Thank you, sir. Thank you, sir. ये record leave करो, हाँ? Leave meeting.